there's a lot more to women than sort of the reproductive organs. And the heart is definitely a lady part, considering the fact that there are more women that die from heart disease than from all cancers combined. So, being a woman definitely increases your risk. And without getting into the scientific data behind it, just to simply mention the fact that our chambers are differently designed than men's are. They're smaller, some of them are thinner. The way that the valves at times move are at increased rate. The reason for that is because our baseline heart rate is sometimes elevated and higher than it is for a man. The stress that our vessels feel from that extra heartbeats is definitely different. So the way that our heart remodels is very different as well. A woman's vessels are also a lot more sensitive to stress and inflammation. And stress is one of the leading causes of heart disease, as we know, except for the fact that we can't really pinpoint it. We can't say that like we do with diabetes or with high cholesterol. We know the fact that stress induces inflammation, and that inflammatory response puts a significant strain on the heart, on the vessels, and on the valves. Women, especially during their reproductive years, use their OBGYN as their primary care physician. And at that period of time, again, going back to that bikini approach, they talk about their reproductive organs and they very rarely forget to mention about their heart. Not because of the fact that they don't remember, it's the fact that they don't really think about that they are at risk for having heart disease. That awareness can actually lead to early diagnosis, can actually lead to prevention of heart disease. And 80% of cardiovascular disease is preventable. So when a woman is going to see her OBGYN, who's her primary care physician, she has to be able to bring up the fact that she may be having something that just might not feel well. And especially if she's looking to potentially get pregnant, because we know the fact that there's certain risk factors that take place during the time of pregnancy that increases their risk for maternal mortality at that period of time. The reason why pregnancy is considered a stress test, it's not because of the fact that, we're running around and trying to plan our baby showers or trying to potentially get the right color for the room. The reason why it's called a stress test is because of the fact that during the time of your pregnancy, physiologically, your body changes. Your heart has to pump significantly a lot more blood, whereas usually a woman pumps anywhere between 4 to 5 liters of blood per minute. Now we're pumping close to approximately 8 liters of blood per minute. And that's a significant increase. Our vessels change. Some vessels actually get very dilated, and then subsequently they get very, very narrowed and restricted. And that type of hemodynamic change is what's considered to be a stress test. Before the pregnancy, every single woman needs to understand that the better cardiovascular shape she's in prior to the pregnancy, the better the pregnancy, the easier the pregnancy, and the less likelihood of her developing any type of issues during the time of the pregnancy. So what does that mean? It means that simply being able to eat well, eat healthy, follow a Mediterranean diet, stay physically active, and just like the AHA always recommends, at least 30 minutes of cardiovascular exercise 5 days a week. That in itself is a significant improvement in their underlying cardiovascular health prior to actually getting pregnant. Also, if you know the fact that you carry that potential genetic predisposition, that is something that your OBGYN, who you are using as your PCP, should know. That old school mentality of it's just pregnancy related, I'm short of breath, so it must be pregnancy related. My legs are continuously swollen, so it must be pregnancy related. That is by default, that is a diagnosis of exclusion, meaning the fact that if you've already excluded the fact that this is not anything else, this is not something serious with your heart, it's not a new cardiomyopathy or a weakening of the heart muscle, then yes, then you can say the fact that this shortness of breath or this swelling is because of my pregnancy. But I think that the era that we live in, we do have to be a little bit more cautious because A lot of women do get pregnant at a later age. A lot of women that do get pregnant, they get pregnant with underlying risk factors such as hypertension, and that in itself puts a significant strain on the heart. So the couple of things that we can change, and that is sort of our hypertension and obesity, which is 2 out of the 4. Things that we can change is obviously something that such our age and race and ethnicity. Preeclampsia falls under the umbrella of what's called now adverse pregnancy outcomes. Adverse pregnancy outcomes are what we now know can potentially lead to long-term cardiovascular effects for women, and those are some of the risk factors that actually lead to that increased maternal mortality. Preeclampsia in itself is elevation of blood pressure that can actually affect other organs, including the liver, including the kidneys. And that's why when a woman is going into her OBGYN office and she's pregnant and they note the fact that there's potential elevation in her blood pressure, they immediately check her urine for protein. And that is to see whether or not that high blood pressure is not putting any strain on the kidneys. Preeclampsia is also on this fluid sort of staging, and because it's preeclampsia, it is severe preeclampsia, it is HELP syndrome, right? So the difference is that there's significant features that can actually progressively get worse. The other adverse pregnancy outcomes are spontaneous preterm delivery before the week of 32 and intrauterine growth restriction. We never in the past actually thought that by having a small for gestational age fetus can potentially affect maternal mortality, but it does. And it also increases her risk for developing underlying cardiovascular disease later on in life. I think one of the biggest improvements that I've seen in reference to cardiology, and this has been pertaining to cardio-obstetrics specifically, is the fact that we're beginning to learn the fact that cardiology alone and heart disease alone can never just work in silo. We have to collaborate, whether or not it is collaboration between our OBGYN and MFM colleagues, whether or not it's within the adult congenital group colleagues, but we have to work together in order to genuinely improve the health for these women and to decrease the maternal mortality.